Hi, Rachel, and welcome to the No Stroke Podcast.
Hi, thanks so much for having me.
Yeah, of course. I do see before we get rolling too deep, I see a hockey jersey in the background, and we're without my co-host David today, but I know he would definitely appreciate it. So is that Washington, if I'm not mistaken?
This is
Or am
actually
I in?
Chicago, where we were for a
Uh,
long time. So I'm camping out in my husband's office today, and he's the Blackhawks fan.
okay. Now David's a Bruins guy, uh,
Okay, well, they
so
would have a
yeah.
lot to talk about, I'm sure.
So, are you a hockey fan yourself, or?
I when the Blackhawks were doing really well a few years ago, I got on the bandwagon, but
Okay.
now
Okay.
Green Bay Packers actually are my team.
Nice cheese. I could see in the audience with the cheese hat on.
Yeah, exactly.
Die hard. I love it. Uh,
Yeah.
so we got connected recently enough, but I think my mom's actually been, with your stroke with your outpatient support program for a little while. And you've, been connected in with Carolyn Brown from Stroke OT. So, great to see you and the rest of the team up at our annual fundraising event last month.
Mhm.
And I know you guys are doing other things in the community. So really excited to kind of have you on here today, talk more around, specifically what you're doing at Yale later in the conversation. But um, really want to focus on, some of the new guidelines that the American Stroke Association recently published for prevention. This has been, I think, the last time guidelines or prevention guidelines came out I think it was about a decade, right? The
Mhm.
2014, if I'm not mistaken.
Exactly. Mhm.
So yeah, there's some interesting new additions here. Right, same, definitely still kind of the same MO of, lifestyle improvement, right? Not sitting on your butt all day like I do at work, but we'll dive into that. But first, let's just kind of for our audience, can you give a bit of background of your career to date? And kind of what motivated you, I guess, to get into the stroke space as a neurologist?
Definitely. And first of all, Michael, thank you so much for having me here today. This is such an amazing platform that you've created with your partner here. And I'm just super grateful that I can be here today and that this exists for stroke survivors and people in the stroke community.
Thank you.
So I am a stroke neurologist at Yale. So I treat people from, having an actual stroke in the emergency room, taking care of them in the hospital after a stroke, and then I have a clinic in Guilford, Connecticut, where I treat people who've had strokes also with, stroke-like symptoms, who may have had a stroke or who have irregularities with their blood vessels of the head and neck. And I've been here at Yale since 2020. And as I've alluded to, I'm from the Midwest beforehand. And really, I just connect so much with stroke survivors and what they've been through. And as I'll talk about later, the impact that education in the community to teach people about stroke prevention and how important it is to recognize stroke symptoms really, motivates me every day to do what I do.
Yeah, it's, important work and obviously Yale carries such a name here, especially like I mean across the world, but especially in the Northeast as that trusted brand community. So I mean, it's living in the area. I say, Yale's name out a lot. So I know, having programs like this, and again, really interested to kind of dive in deeper to the work that's happening on the ground. But I
Mhm.
think again, one thing we'll probably touch on as well. It's like that, people are always looking for the trusted source, trusted brand, because everybody could go to Dr. Google and these different areas. So, thank you for mentioning, us as a platform that people are using, but it's really the providers like yourselves, the nurses that you have in your care team that people need. And it's amazing that you guys are that outlet for folks, especially in the local area. Um, so I guess before we dive into it, we talked about hockey at the beginning. So if you're not out on the ice to kind of take away from the stress of your day to day, how do you disconnect outside of work?
It's ironic that you say that because one of my favorite things to do is snowboard.
Oh,
But
awesome.
I will say that in the last 4 years, I now have two little boys, so there's not a lot of free time happening. But just finding ways to, spend quality time with my family, my husband and my two sons and dog. And, I did bring my 4-year-old out to the stroke OT event. So I've started bringing at least him and actually the baby ones out into the community, and he loves it. He goes from table to table and tries to get the giveaways, and fusing the two together has been fun. A lot of people think it, has to be either or, but making it kind of a family thing on the weekends is a nice way to give back and also just teach them from a young age how it's really important to give back to your community.
It's special. And for you to not live a sedentary lifestyle with it, chasing around to young kids as well, right?
Definitely
That
not.
helps. That helps.
Yeah.
Uh, all right. So let's jump into these guidelines. Again, mentioned these are updates from, the 2014 guidelines. I think let's start with, and it's been a buzzword for the past few years, right? Social determinants of health, right? So
Mhm.
these social factors like economic barriers that, cause greater stress or stroke risk. So I guess from your side, like, why is it important that we consider these factors for stroke prevention? Maybe talk through like what are some additional factors that fall within this social determinants of health.
Sure. Yeah, this is so important. And we're realizing that social determinants of health are actually stroke risk factors, not just the medical things like high blood pressure and high cholesterol, which of course are so important, but social determinants of health, which I'll talk about, are risk factors for stroke and other medical problems. So this is where people are born, grow up, and live and spend their time. For instance, how much money someone makes a year, how their access to health insurance, their education level, being socially isolated. Being socially isolated can actually increase risk of recurrent stroke up to 2.5 times. And I've started to actually bring some of this into my conversations with patients in clinic. Of course, we only have so much time, but in addition to talking about how important it is to manage blood pressure, I started asking, tell me about your social network. Do you stay home by yourself all day? Do you have meaningful conversations with people? And I try to help people find avenues to connect with others, whether that's getting out to a community center, so a senior center. But beyond, just social isolation, it's also going back to the resources someone has. And you can imagine how different it is for someone who is more well off, lives in a community where they can just get in their car and drive to a gym within a couple minutes, or have the money to go to Whole Foods and buy like every healthy option and get a nutritionist and a personal trainer, drive themselves to doctor's appointments, versus someone that doesn't have those options. And I think we need to tailor our conversations in the hospital, especially as we're getting ready to send someone out, and in the clinic, because we can't just give a blanket recommendation to everybody and expect people to do the same things, because it's just not realistic. So I'm really glad that they've incorporated this into the latest guidelines.
Yeah, and are there, I guess, as a practicing, physician, like how are these screen? Is there a standardized tool for screening for social determinants of health, or how are you guys currently screening for that and kind of understanding where they fall, I guess, within the bucket?
That's a really good point, Michael. We don't routinely have a screening tool, at least here with our stroke population. There are some screening, surveys that are out there, but I think that it's something that we need to really start doing a little bit more objectively and methodically, as opposed to kind of an afterthought. And I will say that we have amazing nurse navigators at Yale and social workers. So it's not like we don't do this at all. Like, they're very thoughtful about every step of the discharge. They call people within the week after they leave the hospital, especially kind of more high risk people. So we're, really doing the best we can. But I think that, having a little bit more of a tool to make it standardized could be a great way to, take it to the next level. Um, and every day, I mean, on the inpatient stroke service at Yale, we're seeing people who have exorbitant, stressors from social determinants of health. And even in my own clinic, I just saw someone yesterday, we were talking about how to exercise. And I said, well, how can we make this a reality? She doesn't have transportation. She can't afford a gym membership. She can't go for walks because she, uses a walker, so she can maybe do a little bit. But, how do you tell someone, and this is like so many stroke survivors, right? So you have to get creative in how to help people who have more barriers achieve a healthy lifestyle.
Yeah, and exercise is one that is within the guidelines we'll touch on. I guess the other one, and you touched on it there briefly, diet, right? So it's
Mhm.
recommended here that people incorporate the Mediterranean diet. And again, it kind of all stems up, not as we continue to talk through these guidelines here, it really does stem to that first one around social determinants of health, right? Because
Yeah.
the economic barriers of, like you're saying, going to shopping at Whole Foods or your local, farmers market, I guess, to get the
Hmm.
freshest quality food. Um, you know, in your role, how are you helping patients that again might be trying to incorporate but have some barriers? How are you kind of helping them be somewhat realistic and start setting goals around eating better?
Yeah, and it's very patient dependent. So I think really trying to understand instead of just saying, please follow the Mediterranean diet and have a nice day. Like
Yeah.
people are going to say, what diet? And then probably
Right.
not do anything. So I will just start by trying to understand what someone eats in a day. And a lot of people know exactly what they're supposed to eat and just don't do it for whatever reason. I mean, we probably all fall into that category sometimes where it's just easier to go to McDonald's or, not eat something super healthy like we're not always in the mood for a salad. So just understanding, is it like what are the barriers for eating healthy? And maybe someone already is, and that's great, and just kind of give them a pat on the back and focus your efforts on a different aspect. But for people really struggling with diet, sometimes it's that. Sometimes people just really don't know what they're supposed to eat. And they think they're eating healthy, but they're actually doing the total opposite. And maybe they're doing things to spike their blood sugar all day and thinking that it's healthy. Like someone was having the other day, like fruit juices, thinking that was healthy. So I said, maybe let's substitute that for water. Or if someone is really, gets so much pleasure from their little, drinks, or someone was, love drinking those glass Frappuccino bottles every day. I said, why don't we dump half of it out, kind of like I do with my toddler's juice, and fill the rest with like a bunch of ice and maybe a little bit of a protein, like a chocolate protein shake. It probably would taste 99% the same, but you're getting a lot more, healthy aspects to that. So really just trying not to make it like this Mediterranean diet's out there and you have to follow it to a T. Like let's just start thinking of, little substitutions. So maybe instead of having red meat every night, have fish 1 or 2 nights instead, as opposed to like going from 0 to 100. And the Mediterranean diet is really just eating healthy, vegetables, trying to substitute, fish with instead of some red meat, not having too much dairy. If you like nuts, have a handful of nuts. I even said like dump half a bag of Fritos or Doritos out and so you can still get it, but also have like nuts, with your snack and just try to be creative where it's not like an end all be all thing is the way that I think my patients have had more wins.
Nice. And so many of these kind of tips, right? Like it transitions into, how you need to be thinking about lifestyle changes as well,
Hmm.
right? So not just, and I guess when I say lifestyle changes, talk physical activity, right? So one thing that I'd say is really changed since these guidelines have come out is sedentary behavior, mainly driven through the pandemic and work from home changes in maybe younger stroke instances. Older stroke instances, probably the isolation aspect, like people not going to community centers, things like that. So let's touch on that one. The guideline, within the bucket of kind of lifestyle is reducing sedentary behavior. So how have you seen that change over the past decade? And again, this is a tips and tricks episode here from you. So like, how are you kind of dealing with that in clinic?
What, I have to just remember before I forget for the previous question, I want to make sure people are aware that a lot of dietitians take insurance. And there's
Mm,
something at Yale called the Teaching Kitchen, which is with insurance. And it's a great program where it's virtual as well or in person, and they teach you different ways to cook healthy foods. But as
nice.
far as
And is that like a in-person thing, a virtual thing people could
either
get
or.
connected
I
to?
believe
Oh,
it's
great.
either or. You just need a referral from your Yale physician or nurse practitioner. And when they put in like the referral to nutrition, it's one of the options on the referral, the teaching kitchen.
Awesome. Yeah, I'll put a link in that in the show notes. Thank you.
Great. Yeah, I mean, it's tough. People need to get out and move around and ideally get their heart rate up with some, more vigorous exercise. So I think just again, it's very individualized. Does someone have a dog? Okay. If you're already out walking your dog, maybe try to find a couple places with hills, and that way it's not like this separate entity of exercising. For some of your young listeners, one of the things that I've actually had to start doing is exercising while I'm watching my kids on the floor, because they're just running around and playing on the floor. So I will start to do, well, probably like not the best push-ups, but whatever I can do, sit-ups. I have a little, even right here, I have a weight. This was not planted. Just wherever you can fit them into your day, just do it. And especially if let's say you're sitting at a desk all day doing a remote job. I've seen some people get those walking treadmills that you can stand on. You can get the thing that goes under the desk where you can, I think they're on Amazon, like the little bicycle for that you can do under the desk. Weights. Maybe you could, if there's a meeting that you could just listen to. You could do it while you're out for a walk, perhaps. I mean, just incorporating it into your day because people's days fill up so much, and sometimes having like, oh God, I still have to exercise. Now it's dinner time. I'm not going to want to exercise after dinner. And then it's like you feel like a failure because you didn't exercise. So instead, maybe just like infusing it into part of your day can be helpful. And for people that have disability after a stroke, of course, you have to be creative. So getting ideas from physical therapy, I believe you also, the stroke OT has a lot of great ideas, right?
Yeah, yes, we're doing a lot and just different, like, we have chair yoga and
Yeah.
like things that, help because it's funny you say that because it's like there's always like that stigma against going to a gym or kind of get like starting exercise after a stroke, right? And
Mm-hmm.
like, is that a conversation you're having as a neurologist kind of in that post-discharge phase, or do you kind of lean into more of like your stroke navigators and some of those folks? Because it's usually right as much as you want to start exercise immediately and kind of your rehab, you're kind of being handheld by your PTs in the first probably 3 months, right? And it's often like that gap from like 6 months to 12 months post-stroke where people either continue or they're falling off, the cliff and really no support there and trying to get people back into a program is difficult. So how are those conversations, again in clinic, like motivate, I guess part of it is motivation and part of
Mm-hmm.
it is finding a program that works as well, right? So
Totally.
yeah.
Yep, you're right. And I think that we don't emphasize exercise enough, to be
Mm,
honest. We have a couple of trials that we've done that show that exercise is probably the most important aspect of stroke prevention, especially with people that have, disease of the arteries in the head. And I always tell when I'm on rounds with the students, I say, how often do you tell someone to exercise? But I know that you're telling them to take their medications, and it's just as important. But and we have all these avenues to try to get people their meds for free, and we need to put the same stock into helping people do good exercise programs.
yeah.
So I think, it's tough because in the hospital, a lot of times people are overwhelmed and don't always remember the conversations we have with them. But then, there is this gap. But I definitely infuse it like right as I meet people in clinic after their stroke, and we just talk about how to make it a reality. I can't just say make sure you exercise, because that means so many different things to people. And they have the Silver Sneakers program, which, are you familiar with that?
Yeah, yeah. Actually, when I used to work at a Health Tracks, which is like a local chain up here in the Northeast,
Okay.
and we had a Silver Sneakers program that we would support after. And yeah, it's a nice benefit. I think it's for like the Medicaid or Medicaid,
Yeah,
Medicaid,
yeah,
yeah. Um, and yeah, it's a insurance benefit that covers the cost
hmm,
for your programs, which is a nice added benefit. And yeah, again, when we go back to social determinants of health, right? Like,
yep,
a
exactly.
convenient way for you to be able to get into the gym free of charge. Although I
Yeah,
would say, usually when you have some skin in the game and you're paying a little bit, you're more motivated to go to the gym. Um,
that is true. Yes.
yeah, yeah.
Yeah.
And let's just quickly touch on, I think we've kind of talked, exercise more in maybe the post phase, right? Like for recoup, but let's just talk about like the importance of exercise and prevention, right? Since that's a topic. Like,
Hmm.
we've talked to many survivors that have, unfortunately dealt with the stroke, even being a fit, active individual. But I think it's the recovery aspect for them, right? Like they were able, because they had that instilled in them, like working out, like they were able to make a greater recovery. So just quickly, kind of, in your experience, I guess, like the importance of a fit individual, and I guess to prevent them of stroke, but also like how that helps in the recovery phase.
Yeah, definitely. I think that we need, and again, I'm not typically seeing people, that are young and before their stroke, but in
Yeah.
general, it's so important to emphasize diet and exercise just in general. We are seeing that people who have uncontrolled risk factors, even if let's take stroke out of the equation, let's say you and I, if we have a high blood pressure in midlife, we're more likely to have dementia and stroke later. So this all matters. And they actually looked at people in their 30s and 40s, and they're all the same risk factors. So if stroke doesn't, scare you enough, or, get you motivated enough, dementia is also just as equally impacted by these healthy lifestyle and cardiovascular disease. So whatever, again, it's so individualized. You have to figure out what the barrier is for that person. Is it time? And much of it is a lot for people that are working with children. It's time, right? Like, how do you fit that into your day, outside of waking up at 4 in the morning, right? Or is it that someone doesn't have the money to work out, or a car to get to a gym? So just coming up with creative avenues, and I think that needs to be a routine part of a conversation with a primary care professional. And I think a
Mm.
lot of people are doing a great job with that, but having it be standard as part of, what people, and saying like, okay, not just saying you need to make sure you lose weight and exercise, but go into detail of how that's going to happen for each person individually. It's so important.
Yeah, yeah, and that's the key, right? Like getting creative, but you would the primary care route is seems like that's where the conversation should be happening, but unfortunately, it's just like the amount of people actually going to a PCP every year, and then the amount of time that you get with a PCP is quite. I think the average is like you get like maybe 14 minutes with your PCP every
Yeah.
appointment, and they're flying through. So yeah, I would love to kind of see, other avenue or other kind of touch points, for a lack of a better term, like that could be used to talk through, some of these, prevention tips, whether that, it's like your local pharmacist. That's where I
Hmm.
used to, that was my first job in college, or yeah, in high school, was at a local pharmacy. And it's like the amount of FaceTime you're getting with folks on a weekly, monthly basis is probably greater than even in the PCP avenue, So I think it
Hmm.
like also kind of comes down to, how providers and advocacy groups like the American Stroke Association think about ways that we could touch lives and get this information through. Obviously this podcast doesn't have millions and millions of listeners, but it's one avenue.
Yeah,
But yeah, I think we just need to do a better good job, like as a whole, to get this message out.
totally.
And yeah,
Yeah. We need to
'Cause-
find out also what motivates people, right? Like, and we
mm,
actually, I'm glad you brought that up because I am, if we have time, I am part of a group that's in Derby, Connecticut, that's
okay.
trying to make prevention a community-wide entity where we're
Hmm.
not just relying on individual, healthcare professionals, but and when I say we, it's a group of us at Yale and Griffin Hospital. We have partnered with the town of Derby, and we're trying to, through grant funding and buy-in from the town, starting with blood pressure, because we feel like that is the biggest risk factor that we can start tackling first for
Yep.
dementia, stroke, and we're going to see if we can tackle this on a community-wide level and what that messaging is going to have to be to get people to buy in and really care about taking care of their health. And we're starting with really just, being there for our families and being healthy for our families. So that's more to come on that.
Cool. Well, yeah, we could talk through that, and it kind of rolls into another, one of these guidelines around blood pressure control. So as we're on the topic, why don't you again just briefly kind of talk through, what blood pressure control means for, stroke prevention, and maybe just again like what ballpark do you want to be in? What's a good blood pressure? What's bad? And how could
Mhm.
somebody just, if they're interested today, are there easy ways just to go find that blood or go take their blood pressure without having to be at a doctor's office?
Yeah, it's so important for blood pressure control. And the sad thing is so many people live for their whole lives with uncontrolled blood pressure. And the first time they find out about it is when they come in with a devastating stroke. And it's tough because people, I mean, some people say, oh yeah, when my blood pressure is really high, I don't feel well, but the majority of people feel no symptoms with high blood pressure. And it doesn't just cause stroke, it causes heart attack, dementia, kidney failure. I mean, basically wreaks havoc on the entire body. And the way to know you have it is to check it. And we have to make sure people are checking it properly. So if you're gonna invest in a home machine, make sure you look up, there's some great videos actually with the American Heart Association. There's a 3-minute video of a woman in a yellow shirt that's fantastic. And that'll teach you how to check your blood pressure at home. So if you want to invest in this, you can get a cuff from the pharmacy or Amazon. Omron is a very trusted brand. And you can, watch the video and start monitoring your blood pressure at home and bring a record in for your primary care provider. Some grocery stores and pharmacies, I think this shut down a lot with the pandemic, still have machines where people can go get them checked. There's also health fairs. So we were at a health fair a few weeks ago and we were doing blood pressure screenings. So you might reach out to your community center and see if there's events coming up. Or just, next time you go to your healthcare professional, you'll see what it is. And if it's high, you can't just come back in 6 months. You have to invest in that machine. Typically, we recommend less than 130 over 80. But again, it's very patient dependent. I would say if you're, just someone who's checking it at home and getting a lot of 140s, 150s, that's concerning, and you should probably mention that and sooner rather than later to your provider.
Great. Yeah, and I think some other spot like I've seen them at Stop and Shops, for instance,
Yeah,
right? Like grocery
yeah,
store, there's it's often the chair you can throw your hand in and you could get that read. So yeah, you just keep an
right.
eye out, and yeah. Certainly an important aspect of prevention. Um, another, so let's kind of move on to, and you mentioned it briefly, but around medication management. One again buzzy thing that I think has kind of hit the market here recently is GLP-1s, right? So this is
Mhm.
mainly, you know, your catchy commercial for weight loss medication that you see, going
Yeah.
around. And, it's certainly here in the States, become a very, very popular weight loss medication.
Mhm.
But we've seen this be used obviously for like it's prevention of diabetes, but now there, some studies that have come out speaking to stroke prevention.
Mhm.
So let's talk through that. If there are like maybe one, let's just start with like what do GLP-1s do? Like what is the purpose of the medication? And then, we could touch on how that impacts stroke prevention.
These GLP-1 receptor agonists, the full name are glucagon-like peptide 1 receptor agonists. And what they do is they mimic the hormone GLP-1 and that's natural in our bodies. And GLP-1 gets released in the gut after eating and prompts our body to produce insulin, lowering blood sugar. It also helps regulate our digestion, so it slows that down so that you feel full longer, and then acts on the brain to suppress our appetite and fullness. Well, it makes us feel full and suppresses appetite. So it really, just gets everything slowed down and makes it so that you're not as hungry. Also, some people feel like the food chatter. So people that are just thinking about food all day and craving different things, that food chatter kind of quiets down. And this medication is not like a new medication as the last, year or two. It's been around for diabetes. And, they've noticed that people tend to lose weight when they're on it. So the guidelines go over a number of clinical trials that have shown various, good effects from the medication. So there was one that they listed, Sustain 6, that found that it reduced stroke risk compared to placebo in patients who had diabetes. And then the main one that was in the New England Journal is called STEP, the STEP program. And they found that they lowered the risk of cardiovascular events and also decreased the progression of chronic kidney disease. So there seems to be a number of benefits, including weight loss, of course, which is why a lot of people, at least now, are starting it. I just want to mention that if you are going to start it, you also still should be doing other, health measures like eating healthy and exercising, because it can also reduce your muscle mass on top of just the weight loss. So you don't want to just say like, okay, now I'm on this miracle drug, I'm gonna like eat pizza and then I won't eat as much and not work out, because then it's really unhealthy for you. So it's meant to be kind of in conjunction with a healthier lifestyle.
So it's not a magic pill. Everybody's looking for the magic pill.
Yeah, right. I mean, it's pretty close to being magic, I would say, but you have to be wary of of
Yeah.
things that are too good, right?
And how is this covered? If you have, and I'm not sure if you know this, but just like insurance reimbursement, like is it, something you have to get kind of referred from a PCP, or how's that work just in
Yeah,
terms of
yeah.
getting the med?
Typically, you need a referral. At least I believe there might be some online programs where they have their own healthcare professional that sees you. I think the WW, like the Weight Watchers program, they actually give you your own nurse practitioner or PA that meets with you and prescribes a medication, and they work with your insurance. Or you can go through your primary care professional. I think if you have the diabetes history, your chances are a lot higher compared to not, if it's just purely for weight loss. But I think it just depends on what the provider puts in the referral and what insurance type you have, if it's going to get approved or not. So I would just say if it's something you're considering, have the conversation, see what they think. And then if it's covered by insurance or not, there's different options. I think like if you purchase it directly through Lilly, which is the manufacturing company, then you can get it for cheaper than like completely out of pocket, if your insurance doesn't cover
Yeah.
it. So there's different options to not pay as much, but that's still, a couple hundred a month at least.
Okay. Cool.
Yeah.
So I think the last part here around these guidelines are gender specific.
Mhm.
And I think we've seen, some science come out and publications around women's health and women being more prone to stroke, right?
Mhm.
Um, in one conversation, there's a woman, sitting with the stroke in young adults program. She's Alyssa, but she's kind of focused within stroke pregnancy
Hmm.
and stroke risk. So I think we'll try to have her on deeper conversation as it relates specifically to pregnancy. But can you
Right.
cover for us, some of the guidelines around, women's health, and kind of what makes women more prone to potentially being a higher risk of stroke?
I'm glad that they included this in the guidelines this year. It's very important just for people to be aware that these are stroke risk factors, what we call pregnancy adverse events. So people that have premature deliveries, very much having high blood pressure during the pregnancy, which is called gestational hypertension. And endometriosis. There's a lot of they list them all out in the guideline, but there's a lot of different, sex specific risk factors, especially related to pregnancy. They also actually give like a really nice flow chart in there, like, for providers or even the patients to look at to see if if you have all these different pregnancy associated complications. Not
And
that,
do
go
those
ahead.
and sorry, do those kind of range like that it's that risk of stroke, is that kind of in the, third trimester? Is that during the like birth itself, or in the immediate kind of stages after birth? Do they kind of get granular to that effect, and like different types of risks within those pockets?
Yes, they do look
Yeah.
at different types of risks throughout the pregnancy, even postpartum. So
Mm.
if you have, and it's really, again, there's not much you would necessarily do differently, but at least you can be aware that this person is at a higher risk for stroke. So for instance, if you have a patient who's now, in her 50s and she said, "Oh, I had really high blood pressure with my pregnancy," then you might be a little bit more, apt to keep an eye on the blood pressure for that person, knowing that this could be an issue down the road. Be a little bit more mindful for people that have endometriosis, for instance, that they are at a little bit of a higher risk for stroke, and just, have that in your back pocket, as opposed to really a change in treatment.
Okay. And
Yeah.
there's also a specific call out for you know transgender women on hormone therapy.
Hmm.
So again, that's, I'm not sure if that's something within your clinic, or kind of how these conversations are coming in. But again, any
Hmm.
specific feedback for how physicians as well as patients could be thinking about that.
That is the same thing as before, where it's just something to be mindful of. And maybe if
Yeah.
someone is on hormone therapy, you're gonna manage the risk factors a little bit differently. If they're on other things that could increase the risk for clotting and stroke, you just want to be mindful of that. So it's again just bringing awareness to the fact that the hormone therapy could be an elevated risk factor for stroke, and to adjust any other treatments or risk factor management accordingly.
Okay. Perfect. So I think that about covers it for, the guidelines. We had a phone-in question from my co-host David here, who's not able to join us today. His question pertaining, over the last 10 years, right? There's been a new pile of evidence coming out, new guidelines, new ways people live in general, right? We're talking about, remote work, increased sedentary behavior.
Mhm.
Um, how, and be curious, like, just the insight you have into this, but how are these new guidelines, set out, right? Like what goes into that? And then I suppose, like, if we were to think, 10 years out again, what are some things that you could envision kind of coming in and over the next 10 years to these guidelines as they continue to evolve?
Great question. I think that it's so important to be thinking ahead like that and deciding how are we going to hold ourselves accountable for these guidelines and make sure that we are, helping people with social determinants of health and getting the word out there about sex specific risk factors and the life essential 8, which is again how all the different risk factors for stroke and dementia. And, we have to start changing some of our interventions and research. I think it all kind of goes back to that. And our funding mechanisms need to be in line with the
Mhm.
type of, you know, recommendations we're putting out there. So, for instance, there was a publication done by a woman that I cannot speak highly enough of, Bernadette Boden-Albala, who is really like, are you familiar with her? You're shaking your head.
Yeah, yeah,
Yeah,
yeah,
I mean,
yeah.
she's
She's
like a
awesome.
pioneer for stroke social determinants of health. And she put a paper out last year in neurology about how are we doing in the neurology community for these types of interventions that are interfacing with our community to address social determinants of health. And the short end of it is not well. I mean, there are some great people out there doing amazing work, but as a whole, out of all the studies that involved, diversity and community engagement, only less than 20% actually partner with the community, which is not a lot. We need to be partnering with the community to understand what the needs are. And
Yeah,
that's something that, we've started working with the Community Action Agency of New Haven, which is a fantastic New Haven-based community organization that really supports people holistically, with any issue that could come up from a social determinants of health standpoint. And how do we partner with places like that and be aware of all the great resources in the community? We can't just say, hey, do this, this, and this to take care of yourself and have a nice day. As I said earlier, we have to give them the list and resources in the community. I believe they're actually brought up a farmer's market. I think there is a farmer's market in New Haven that's geared for this,
hmm.
maybe in the summer. So telling our
Yeah,
patients about that could be a great first step. And really, I think making sure that our funding and our publications and research starts shifting in this direction more, in a stronger fashion.
yeah. That makes so much sense, right? It's
Yeah.
having that local community feel, right? Understanding what they need to connect to, what are the barriers locally, really
Hmm.
will drive the change. That's that's great. And maybe let's kind of move into here now, like what you're doing with Stamp Out Stroke. And is that, just a Yale back program? Is that kind of gravitate more to what you're doing at Guilford out of that clinic? But maybe let's spend some time and, talk us through what you're doing with that program.
Stamp Stroke was actually founded in 2005 by Kara Nystrom, who is a stroke advanced practice nurse practitioner at Yale, who's still with us.
Okay.
She's like the heart of the program. And when I joined back in 2020, things had kind of, calmed down a little bit because of the pandemic. So we kind of got together, reinvigorated for community outreach and Stamp Out Stroke. I always say we have a simple mission. We want to educate as many people in the community as possible about stroke and brain health risk factors, like we've been talking about, and the importance of recognizing stroke symptoms because the treatments are time sensitive. So we don't want
Okay.
people waiting around. We do tend to focus our efforts in more under-resourced communities who need us the most. And yeah, we have medical students, nursing students, stroke nurses, stroke fellows. We have a great group of volunteers. We're very active. We've educated over 2,500 people since 2021 with over 60 events. And we were really grateful. We won the American Stroke Association Group Hero Award last year. Yeah, the AHA has been great with helping us spread the word. So,
Yeah,
yeah.
yeah. No, that's important, and again, can just really drives home that message of, taking these guidelines right at a high level, but like each, whether that's a local provider group or, support group, like really trying to drill down and understand like what's going to make these be implemented at a local level, right? So that work that you're
Mhm.
doing is so important. Um, and yeah, excited to kind of talk more about, maybe some of the work happening in Derby and how that's happening, like and maybe quickly here. I know we're
Yeah.
we're getting close to time, but when you think about tapping into the community, like what resources are you considering within that makeup and how, like trying to drive this message home?
Hmm. It's so important also for people that want to start working with the community to understand what resources already are out there, because
Mm,
people have done so much amazing work already. There's partnerships in place with, for instance, Griffin Hospital and Yale. We have our at Yale, we have cultural ambassadors, which are actually people that they're two reverends and people that work with Junta, which is
okay.
a Hispanic group in New Haven. And these are already such, they've worked so hard to get trust, and you don't want to step on toes or confuse community members.
Yeah.
So really just partnering with whoever is already doing a great job in this section, if that's something you're passionate about, and learning from them first, and then kind of, maybe sharing your own perspective. It's just so important before, getting started with community partnership, to understand that piece. And then just seeing what the needs are in a community. Sometimes what your agenda is very, not always the same as what is important to them, and finding a way to meet in the middle, and just say, we all want the same thing at the end of the day. We want a healthy community of people that feel good and take care of their family.
Yeah.
And Derby is kind of along those same lines. We've learned a lot from the Derby folks we've partnered with, and we're together working towards a healthier Derby, starting with blood pressure. And we're really learning a lot from our community advisory board there.
Great. Yeah. And I think it just goes to show this is hard, right?
Yeah.
This is a hard thing to do. It's not copy and paste. You need to
Mhm.
have boots on the ground. And yeah, like I loved how you're thinking through partnerships there, because it all comes down to trust, right? People aren't just going to listen to a message that's forced down their throat. Like
Mhm.
they need to hear from a trusted resource, trusted, partner. And yeah, I'm excited to kind of hear how that continues to develop for you guys. So
Yeah.
congratulations on that. And I
Yeah.
guess before we move into the last question, anything, for our audience you want to kind of recap, takeaway message, anything, that you didn't get in here that you wanted to share in this time?
I think that people are hard on themselves every day in clinic. I have patients, especially stroke survivors, that are just so hard on themselves for not doing everything they need to do. And just to be kind to yourself. People are doing so well, just doing the best they can, and take those small wins. And I would say, just for a message for the world, is to get your blood pressure checked, because people don't
Yeah.
understand how important blood pressure control is.
Great takeaway. And yeah, it might, who knows, maybe this will evolve into your magic wand question, but our famous interview wrap up question. So if we were to be able to hand you a magic wand, you could use that wand to, impact any part of the stroke care pathway, specifically prevention or rehab, or, change everything. How would you take that wand and drive your change?
Oh man. Well, it might be a two-part wand. I mean,
Yeah.
I have to always go back to blood pressure, because if people have blood pressure controlled, so, I mean, of course, people have strokes for many reasons, but the biggest risk factor is hypertension and high blood pressure. So my wand would cure high blood pressure. But I also really want to emphasize that something that just breaks my heart every day is when people come to stroke clinic and they've been living with horrible anxiety and depression for like 6 months or however long it's been, even longer, not knowing that that's just so normal and expected for them after a stroke, and that you don't have to live that way. There's great therapists, there's medications, so I just want that would also be part of my wand, is just to help the mental health crisis post stroke that people are going through, and finding a way to make people feel a little bit better every day.
Yeah, that's a great answer. And I think that last bit there around, the mental health aspect of life after stroke, it's often the unseen,
Hmm.
side of stroke that isn't talked about as much. And, it's difficult for folks to kind of bring up and get seek help for. But I think it all drives back to that connection aspect, right?
Hmm.
And we talked about early with social determinants of health, like the isolation being a main driver um, of increased stroke risk. I mean, the isolation in the post stroke side as well is often, driven through lack of, hey, just how could I connect with someone who's been in the same shoes as me right now, right? Like, and
Mhm.
and I think if we could do a better job kind of forming some of those connections, whether that's on the survivor side or caregiver side, and I know it's happening,
Mhm.
but again, I think we as a community could do more to, drive those connections and hopefully, yeah, help kind of one person at a time here. So,
Yeah.
well, cool. I think that about wraps it up. The morning sun is officially blinding me right now, so I think I have to hop over, close a blind here. But yeah, it's been a pleasure having you on here, Rachel. Thank you very much, and
Yeah.
thank you for all the work that you're doing here.
Thank you. I mean, the fact that you're doing this is just amazing. So thank you so much for what you're doing too.
Pleasure. All right. Well, hope to have you back on soon and recap and continue talking through the amazing work that you're doing. So, thank you, Rachel. We'll chat soon.